As Meg said, my name is Danielle Chelminsky. I work here at the Center for Applied Strategic Learning at NDU. I'm also a student at the George Washington University School of Public Health doing a master's in health policy. And a couple things I want to just say before we get started, and I want to make sure, I know we're a little low on time now, I want to make sure we have enough time for discussion. But I have to say, I am doing this master's. I can't say that I'm an expert, but this is something that I am very passionate about, and something that I do want to dedicate my career to, at least. Not a lot of people can say that they're passionate about insurance reform, but I definitely can say that I am. And just, I love talking about this, and I'm trying not to talk too much and have some time at the end, but I do have a lot of things that I want to cover today. So if we could save, if you want to just jot down any questions and comments as we go, I want to make sure we get to all of those at the end, so that would be great. All right. All right, a couple things we want to cover today. First, I want to start off with a little overview about the healthcare industry as a whole, and mostly concentrate on spending, because that's kind of the issue that's been in the news the most. And then talk a little bit about some of the government programs. Talk about private health insurance, which is, for the most part, what a lot of you guys will have. And then I want to do a country comparison to see how we differ from other countries and how our systems are set up differently. And then have some sort of a debate, have some ethical and legal issues that have come up in the news especially. And then if we have some time at the end, I do have a little case study on the pharmaceutical industry. I don't know if we're going to get there or not. We might have to save that for the other one. The other thing I want to mention is that there is going to be a part 2 on the healthcare reform. So I know you guys are going to have a lot of questions about healthcare reform, but I want to try to get the foundation of this and then save all the healthcare reform stuff for the second presentation. Next one. All right. So I want to just start off with this slide right here. As you can see, there's been an enormous growth in spending in healthcare, particularly since the 1960s, when a lot of the federal programs were started. That's when Medicare really came into the scene. In 1960, it was only 27 million, and it was only 5.2% of our GDP. As you can see, this is 2009. It's now up to 17% of our GDP. Oops, can you go back? Yeah, it shouldn't be on auto. That's okay. Just make sure. All right. And it's been consistently growing, especially in the last 12 years. We've seen an enormous growth in spending. Next slide. All right. This is kind of a projection of what's to come. Here we are in 2012 at 17.7%. By 2017, we're looking at almost 20%. There's some estimates that by 2025, we're looking at 25% of our GDP. So that means one of every $4 that's spent in the U.S. is going to be spent on healthcare. So this is an enormous problem. It's an enormous part of our economy. So yeah, can we change it to off of auto? Sorry, one second. Can you, yeah, can you, I guess so this is another interesting slide. As you can see that we spend a lot more than any other country. That's one of the big issues that's been coming up a lot recently. So another big problem with healthcare, is that we've seen a lot in the news, is that there's going to be a huge squeeze on the federal budget, and that's coming pretty soon as we have, we're racking up debt, and we have lots of other spending that we want to allocate. Healthcare is going to be one of the ones that we're going to really have to focus on. As you can see, just Medicare and Medicaid alone is almost 8 or 9% of our GDP. Just in comparison, our entire military budget is 5% of our GDP. So we actually spend almost the same amount on just Medicare alone than we do for the entire military, and we have the biggest military in the world, as you guys all would know. So by 2040, one of the projections is saying that that we're only going to have enough money to pay for our net interest and our Social Security, and so everything like Medicare and Medicaid, we're going to either have to go into debt or figure out how we're going to pay for that, and then all other spending, that's including military spending, is going to be one of the last resorts. So it's an issue that really needs to be addressed. Next slide. All right. So this is the interesting part. What makes the healthcare industry different? Why are we spending so much? What's so different about this industry that's causing all this spending? One of the major issues is that there's just a lot of asymmetric knowledge and uncertainty. So for example, when you go to the doctor, you don't necessarily know. You're not an MD. You don't know what you have. You don't know what your, you know what your symptoms are, but you don't know what diagnosis you have, and neither does the doctor. I mean, the doctor is doing his best to try to figure out what you have, but there is a lot of uncertainty in that. There's also a lot of uncertainty. People don't know, you don't know how long you're going to live. You don't know if a treatment's going to turn out the way it's supposed to. There's a lot of odds and there's a lot of projections, but at the end of the day, every single person's different, and there's just a lot of uncertainty between doctors and patients and you and your own, and people in their own bodies. People just don't know what the outcomes are going to be. And a lot of times I'm sure you guys have had this problem before. A lot of it is trial and error. It's just, we don't know what you're going to have. We're going to do lots of different tests to see what you have, and then go from there and see and just take a guess to see which kind of treatment, using their best judgment, what the best treatment would be. There's a lot of uncertainty also between insurance companies and the patient. There's been a lot of issues recently about people not necessarily disclosing what kind of medical issues they have to insurance companies, and that was a big issue with pre-existing conditions. So insurance companies have to take that risk when they take on a new customer, hoping that they don't have any pre-existing conditions, which they might. There's been a lot of lawsuits about that as well. Another interesting thing about the healthcare industry is this huge third-party payer, which we don't really have in other situations. So, for example, if you go to Best Buy and they say every single TV in here is $10, you're going to want the best TV that there is, and Best Buy is getting 100% of that profit, and then the insurance company is paying for the rest of that. So that happens a lot. That's a simplified version, but that happens a lot in healthcare, is that you walk in and all you're doing is paying a copay or a deductible, and you're not really seeing the full cost of the care. And that's been a big issue recently, or it's been a big issue for a while, ever since insurance really hit the ground, is that you don't really have the same incentives, or incentives are distorted when it comes to either picking a doctor or purchasing healthcare, or knowing what treatment to have. So, for example, if you go to a doctor and you have a headache, the doctor could either say, take an Advil, go home, you're fine. Or he could say, well, we don't know, let's do all these different tests. Here's this $10,000 test that we have that could see, because 1 out of every 1,000 people has this sort of brain tumor or whatever it is. So you think you're getting better care. You're not paying for it. The insurance company's paying for it. And the doctor is also covering himself with defensive medicine. And the doctor also gets a cut of every time that he gives out that test. So he's actually getting paid for that test. So that's kind of where the spiral comes in. And then the insurance company comes in and does all of these utilization reviews. So it's this fight between all three of how the money is being spent. So that's why we overtest in this country, is because it's a huge moneymaker. Another issue that makes healthcare different, and that I'm going to talk a lot about, is government intervention. About 1 of every $2 spent in the U.S. on healthcare is spent by the federal government. So that's very different from a lot of other industries. It's actually one of the biggest industries that has, or the biggest industry besides defense, that has the most federal dollars going into it, and state dollars as well. There's a lot of externalities, so that means that it's very different from other types of transactions, in the sense that there's diseases, there's vaccines, there's pollution, there's the food industry that's causing different things. You know, you see there was a recent case about a shot that came out for an epidural that caused. So there's lots of different ways that healthcare is either spreadable or preventable, and different interests are involved in it. So those are a couple reasons that makes it different. Next slide. So that kind of touches on why it's so expensive. As we talked about before, about $2.6 trillion are being spent every year on healthcare. We spend per person over $8,000 a year on healthcare. That's double any other country in the world, so we spend a lot more. 70% of our GDP. That doesn't mean that we're necessarily healthier. We're only 28th in life expectancy. Japan is #1 in life expectancy, and they spend about 1/3 that we do. Another issue that I touched on a little bit is this issue of moral hazard, is that if you have insurance, you're more likely to use it. It's the only type of insurance that you're purchasing it because you're going to use. So there's been a lot of similarities between car insurance that were made, but car insurance you're hoping never to use. Flood insurance, except for Hurricane Sandy, you're hoping never to use. Whereas you buy health insurance because you're going to use it, and when you think about it, the goal is to spend more than you're putting in as premiums, and so there's a lot of distorted incentives there. Another reason why it's so expensive is that people are just living longer. We're doing a better job at keeping people alive and treating people. 30, 40 years ago, if you had some different types of cancer, that was it. You're 60, that's it. Now we can spend $1 million a year on a very expensive cancer treatment and keep you alive. So that's what's really what's driving up a lot of prices, that we are able to cure things we weren't able to cure before. And that touches on new technologies. We have a lot of fancy CT scans and all these different MRIs and everything that are really expensive, but they are able to actually cure, prevent things and treat people. Another issue that's different from other countries is that 1 out of every 3 adults in America are obese. That's not including just overweight. And that's also leading to a lot of hypertension, diabetes, a lot of chronic diseases, heart disease that a lot of other countries don't have to deal with as much as we do. And also, yeah, I think it's on the next slide. Just one other thing that I want to say at the end here. Everyone wants the best. When it comes to when it comes to your own health or your family's health, money's not usually the same kind of issue that it is when you're buying, a BMW. You get, it's a different type of incentive that you have. So it's an inelastic demand. So if you have, say you're 50 and you get some sort of cancer, and you can either spend $1 million of the insurance company's money to do this new treatment that might give you another 5–10% chance of living, you're going to do it because there's no, it's your life, and your life is more valuable hopefully than other things. So as I said before, the patient is ignorant of what service they really need. So you don't really know which type of test is the best for you, that kind of thing. A lot of uncertainty. Patients are shielded from the full cost. This was actually a really interesting study that they did about laser eye surgery. For example, laser eye surgery came out 10 years ago, 15 years ago, and it was really expensive. And insurance doesn't cover it and never has. I think some might start to now. But the cost of laser eye surgery has gone down tremendously because you are not shielded from the full cost. And they're expensive technologies, but they're able to keep costs down, just like computers are a lot cheaper than they are now. But a triple bypass surgery, which is covered by insurance, and you need that cost has gone up a lot more. So it's the difference between whether or not you're shielded from the cost. Patients don't shop around. If your doctor that you've trusted for the last couple of years says you need this treatment, you're not going to be like, let me get a couple other opinions, whereas you would when you're shopping around for a car or other major investment. Also, a big issue in our country that's different from other countries is lawsuits. A lot of doctors have to practice a lot of preventative medicine. Because, for example, when I gave that headache example, if say the doctor said, you're fine, just take an Advil and go home, and you did have some sort of brain tumor, he's liable. So there's a lot of preventative medicine over-testing, and that's what's really driving up a lot of the costs. Also, our doctors are paid way more than any other country in the world. They do very well. An anesthesiologist, I think, coming out of their residency can make $400,000 a year. So they're doing all right. As I said before, over-testing and duplication. We have a huge issue in this country with health information technology and coordinated care. I don't know if you guys have ever had that experience where you have multiple different specialists and they're not, it's kind of this antiquated technology where there's faxing over sheets of information from doctor to doctor, which in this day and age, I mean, they interviewed someone that said that their auto mechanic has better technology than their hospital does, and that we shouldn't be faxing over information, and we need to have a much better coordinated system. And that's led to a lot of duplication, is that if you had this test done before to see what your blood pressure is or whatever, when you go to a new doctor, they're going to retest you again because they haven't gotten that same information. Another interesting issue in our country that's different is the difference between specialists and primary care. Specialists make a ton of money in this country, and we don't have primary care doctors are really on the decline because there's not enough money in primary care, and specialists actually lobby a lot to make sure that they're the ones that are getting the referrals. So there's a big issue with licensure. There's one interesting story that I read a little while ago about, I think it was in Pennsylvania, where gastroenterologists were fighting against primary care doctors to be able to have the sole licensure over colonoscopies, because they didn't want primary care doctors to be able to do colonoscopies, because that's taking away their business. So there's a huge difference between referrals in this country and primary and specialists that isn't the same in a lot of other countries. All right, so where is all this money going? One of the big issues in healthcare right now is hospitals, and that's something I'll talk about a lot more in the second healthcare briefing and on healthcare reform. Almost one of every $3 goes to a hospital, and that's what we're really trying to keep people out of hospitals, because that's the most expensive place to be. And then 20% go to doctors, and then other spending. 10% go to prescription drugs, which is also a lot more than any other country. And there was actually, and I'll talk about this a little bit more, but Massachusetts just had their mass health, not just a couple years ago, did their mass health overhaul. And they've been finding in the last 10 years that hospital admissions have actually been declining a lot, which is great. That was the whole point of it. But now hospitals are lobbying against Obamacare and everything like that because that's taking away a lot of their business. So there's a lot of different interests at stake. Next slide. All right, I'm sure you guys have dealt with this, and I know you're going to have the same problem when you look at this on Thursday. I think you have the open season. Premiums are going up, and that's just a fact. That's just how our system is set up. The problem is that they're going up faster than inflation, and they're going up faster than workers' earnings. So there's just going to be an increase of more percentage of our salaries are going to be going towards premiums. And that's because of all these different spending. So it's a snowball. The more tests there are, then there's more spending there is one year, then the more the premiums are going to go up the next year for everyone else. This is the same as the same kind of slide. Huge increase in premiums, both from the employer and from the worker contribution in the last 10 years, 10, 15 years. All right, so how are people insured? About half of people are insured through employer-sponsored, so they get it through their jobs. About 30% get it through public spending, so that's both Medicare and Medicaid, and I'm going to cover both of those in a second. The problem is, and it'll show it on the next slide, that only 30% of people are covered under federal spending, but that consists of 50% of all the spending. So it's a smaller group that we're spending a lot of money on. And then this was something that was addressed. This was the major issue in healthcare reform, is the uninsured rate. Next slide. So this is what I was saying before. About half of all of our spending is federal dollars, either federal or state dollars. And for half of the population that's been spending it on private insurance, it's only consisting of 32% of the spending. All right. So let's get into some of the government programs. Medicare, yeah. All right. So do people kind of know what Medicare is? There's Medicare and Medicaid. Medicare is for the elderly and the disabled. So once you're 65, you're automatically enrolled in Medicare. Medicare was actually an afterthought to Social Security reform in the 1960s. They didn't think it was going to be a big program. They didn't think it wouldn't really cost that much. It was it was an amendment that someone put in there. Little did they know it was going to be one of our biggest spending. So right now we're spending, this is in 2011, we're spending almost $600 billion. The defense budget is $700 billion, right? So we're spending almost as much on just the elderly and the disabled that we are on the entire military budget. This is an interesting statistic that I found, that slightly more than a quarter of spending occurs in your last year of life. So that's because you don't know it's your last year of life. So you're holding on for till the very end, and that's where all the spending comes in, is that just because there is this uncertainty of when is death. You don't know when you're going to die. So that's when you're just preventing as much as possible, and that's where a lot of the treatments come in. Huge issue right now is what people call the silver tsunami. That's the baby boomers going into Medicare. So all the baby boomers are just now starting to turn 65, and that's going to be an enormous growth in Medicare over the next 20, 30 years. The problem with Medicare, and I can show you on the next slide, is that it's still not enough to cover all of the healthcare spending. Even that $600 billion doesn't cover all of the medical expenses for the elderly and the disabled. People still have to get supplemental insurance. You still have to pay out of pocket. So it's really only covering just a good portion, but it's still just a proportion. Plus, you're paying into it with payroll taxes and general revenue. So all of that money still isn't enough because it's just an enormous problem. Next slide. And here's the enormous problem. We are spending, so here we are, let's say 2013, at $600 billion. Just by 2020, we're going to be up to $1 trillion in just Medicare. So it's only going up. And that was something that was not addressed for the most part in healthcare reform, because there were a lot of just lobbyists and nobody wants to cut Medicare spending. That's kind of one of those taboo things. Next slide.
Do you think it will go down as the baby boomers die off?
That depends, because people live longer. I mean, it's kind of hard to say. I don't think it'll ever go down. I think the rate of increase will slow, but it'll still go up. I mean, all the projections say that it's going to go up, but it'll just go up at a slower rate. And hopefully, I mean, if something changes, I mean, our expansion just blew up in the last 10, 15 years, so it's also hard to predict at this rate what's going to happen without any major changes. This is a really scary slide. So in 1966, when it was started, there were 19 million people on Medicare. By 2030, there's going to be 80 million. The problem with that is that in 1966, when Medicare was founded, the average life expectancy was 70. So you would get on at 65 and you'd die at 70. Now life expectancy is 78, and they haven't raised the eligibility age for Medicare. So you're on Medicare from 65 to 78 on average, whereas before, when it was started, it was only just 5 years. This is also really scary. So in 2000, there were 4 people working for every 1 person on Medicare. By 2030, there's only going to be 2.3 people working for every 1 person. And that's because of the baby boomer generation. Next slide. A major issue in Medicare as well is and this is in healthcare spending in general, is that 5% of the people, of the population, account for 50% of all the spending. So there's a small population that's really just sucking a lot of and they're the ones with multiple chronic conditions. They're dual eligibles, meaning that they're on Medicare and Medicaid, and they have multiple different issues and multiple admissions in the hospital. They had one statistic of one woman that was admitted to the hospital over 300 times in a year. So it's the small percentage that's really accounting for a huge percent of the spending. Next slide. So a couple issues that they're trying to address in Medicare, which I think are kind of interesting. I won't go through all of these because it's a little boring, but they're trying to see what's a better way to pay. Where's the money kind of leaking to? And hospitals have been trying this thing called bundles payments for a while, which is basically saying, okay, I'm Medicare, and every single time somebody gets admitted to your hospital for a heart attack, we're going to give this hospital $20,000. That's it. You can keep them there for a day. You can keep them there for a month. We don't care. You're getting $20,000. And what they saw what was happening was that more and more people came in with heart attacks, they would actually kick them out really soon. So there was this, whereas before it was fee-for-service, which means that Medicare would pay the bill no matter what. So a lot of people that were on Medicare, they were getting admitted to hospitals, they would stay at the hospital for 15, 20 days because Medicare is paying the entire bill. And then as soon as that happens, they just push them out to kind of outpatient care, and people were getting kicked out of hospitals, kind of assembly line. So another thing that they found was cost shifting, which is basically means that if it's $20,000 reimbursement rate for someone on Medicare that has a heart attack, the next person that comes in who has Aetna or Cigna or Blue Cross Blue Shield, they're going to charge Aetna or Cigna $30,000 for that heart attack to make up the loss that they're making from Medicare reimbursements. Physicians, they did something similar. Medicare did something similar. They basically capped the amount that said, every single time someone comes in, we're only paying you $100 per visit. So what was happening that they saw over the years was that doctors that were accepting Medicare were saying, okay, you have to come up for follow-up visits, and you have to schedule. They would never take phone consultations, come in for a visit. So the quantity went up, even though the reimbursement rate went down. And no one wants to cut Medicare reimbursement because it's not politically viable. To get it back to what they call a sustainable growth rate, we'd have to cut reimbursement rates by almost 30%. Meaning that every single time someone comes in, instead of paying them $100 for a doctor's visit, Medicare would have to give them $70. And what would happen if that happened was that doctors would just stop accepting Medicare patients. So there's a lot of issues with that, and there's a lot of different incentives going on. Yeah, doctors would drop Medicare. Medicare also is experimenting with Medicare Advantage and on Part C. I don't know if any of you have heard of Part C on Medicare, which is basically giving you money, kind of like a voucher system, giving you money or basically paying the bill to say, here, person over 65, go get regular private insurance through Aetna or through Blue Cross Blue Shield and we'll pay for it, and it's managed care. They haven't seen much it was much decrease in spending though. So it's kind of an experiment too at this point. Most expensive people are dual eligibles, and those are people that are both on Medicare and on Medicaid. So they're getting funding from both sides. There's been a lot of issues with the trust fund for Medicare. They're projecting that the trust fund for Medicare is going to run out in 2029. It's run out before, and we've just kept putting more money into it, but that's the next projection. There's been a lot of initiatives to try to control this. One is cutting benefits, and no one wants to touch that. That was a huge issue in Obamacare. And also increased cost sharing. So instead of a $20 copay each time, it's a $50 copay. There's been a lot of different boards that were established to look at cost spending and everything like that, but they don't. It really is going to come down to Congress, and it's just not a politically viable issue. They're talking about raising it to 67, your eligibility to 67, putting people more on managed care, and also I'm sure you guys have heard of the Paul Ryan, the voucher program, which is basically giving people money to go buy private insurance. And I can talk about that more in the health insurance reform brief. This I thought was a funny slide. People don't understand Medicare and Medicaid. They just don't understand where the money's coming from. So some things are just keep government out of my Medicare, and this is no thanks, I'll pass. I don't want the government meddling in my health care, and it's a soldier. Keep government out of Medicaid, damn it. Medicaid is 100% a government-run program and state-run. So I think people just don't understand. Shut Medicaid down now. It's socialism. Go Palin 2012. So this was good. Don't steal from Medicare to support socialized medicine. I just don't really understand. So the whole Tea Party movement and all of the resistance to Obamacare, I think a lot of it was just it's such a complicated issue and people don't understand where the money is coming from, and a lot of congressmen don't want to really put it's such a sensitive issue. Next slide. All right, Medicaid. I'll just do this really quickly. Medicaid is for basically it's the poor. It's people under 133% of the federal poverty, or that's what it's going to be under Obamacare. I'll talk about this more in the second one, but it's also it was one of the major reforms that was put in place during Obamacare. The interesting thing about Medicaid is that it's actually a state-run program. So the states control Medicaid 100%, not 100%. The federal government matches their contributions to Medicaid. So it's actually 50 different systems. So you could qualify for Medicaid in Louisiana and then not qualify or get different benefits in Arkansas. So they're all completely different systems. And there's a lot of tension between what's going to get paid for between the federal and state government. So there's a lot of tension. That was one of the Supreme Court issues that I'll talk about next time. There's a lot of tension between those two. It's still 15% of state spending, so states are really struggling with being able to pay for Medicaid as well. The interesting thing what they set up about Medicaid is that it's counter-cyclical. So that means when the economy goes down, there's more money put into Medicaid, which makes sense because as people lose their jobs, their income drops underneath the federal poverty level, so they have to put more money into Medicaid. 52 million are on Medicaid at any time. It's a pretty big number. It covers the main point, and I'll get to that in the next slide, but the main audience of Medicaid is supposed to be, when it started, it was supposed to be for women and children. That was the idea behind it. So it actually covers 30% of all kids through the CHIP program and 40% of all births. So maternity coverage under Medicaid is very well protected. Next slide. So what they're trying to do under Obamacare, and I can talk about this more, was that basically it's complicated, but basically if the federal poverty level is $20,000, if you make more than that, up to 235% of that, then you're eligible. So it's just a complicated system of who's eligible. And then the problem with the federal poverty level is that you might be eligible, you make less in Mississippi, so a lot more people are under the federal poverty level than they are in New York because the cost of living is so much higher. So there's just an enormous amount of people on Medicaid in poorer states. So there's just a lot of issues with keep calling it since it's at the federal poverty level. But I can talk about that next time. Okay, so this is the part where you guys come in, employer sponsored. So I put this little ecosystem together to try to explain it. It used to be, back in the day, the patient would go to the provider, which is a doctor, a hospital, a pharmaceutical, and you'd pay. You'd go to the doctor, you'd pay out of pocket, and that was it. Now you pay taxes to the government who pays for Medicare and Medicaid to pay the doctors, or they contract with insurers. And if you're on the employer-sponsored side, then you pay it out of your own premiums, and everyone's actually making about 11% less than you would have because of all the benefits. Your full benefit package goes to your premiums. So if you don't, so actually you're losing money if you opt out of having those benefits. And then they contract through PPOs, POS, and HMOs to insurers, and then the insurers pay for the providers. So the problem with having this complicated system is that there's just money flowing all over the place in different directions, and everyone's kind of taking a cut, and there's a lot of different incentives built into this. And it's, at the end of the day, it's an economy, it's an industry, and we look at it differently in that sense. So we look at it as an industry, whereas other countries look at it as kind of a benefit, as a preventative measure. So I hope that helps. So how did we get to employer-sponsored insurance? We came about employer-sponsored insurance very different from other countries. Before World War II, everyone paid out of pocket. You'd go to the doctor, you'd pay, you'd leave. There were a lot less specialists. Specialists are very expensive. There's a lot less sophisticated technology. There wasn't all these other incentives of tests and everything like that. And actually, in the 1940s, Truman proposed a nationalized health plan, and he was called a communist, and they shut him down. And so then after World War II, that's when employer-sponsored health care really started. It was actually a perk to get people working again. It was a benefit, just like it is today, but it started as just being, come work for us, we have this great benefit package, we'll even give you health insurance. And that's really where it really took off. And the good thing about it, why it was looked at as an incentive, was that it's tax-free. So that 10% of your salary that's going towards your benefits is not taxed. Whereas if you just took the wage trade-off and had 10% more of your salary, that's taxed at whatever percentage. So that was looked at as one of the benefits, and it was to get people to have insurance. Problem was, spending really took off, and then ever since then, there's been no incentives to use less. The insurance companies were just paying for everything, and they just couldn't keep paying for everything when there was no accountability on the other side. So that's really where, in the 1980s, when managed care organizations came about, and I think that's when Kaiser Permanente and other HMOs really came about to try to control spending and control costs. Next slide. Problem was that people hated it. People hated not being able to go to the same doctors that they were before because they weren't in network. They didn't like that the doctors would say, sorry, we can't give you that because your insurance doesn't cover it. Or they didn't like all the restrictions, and a lot of insurance companies were denying coverage. They'd say, sorry, you have diabetes, we're not covering that. So a lot of people really didn't like all that. Doctors hated it because they weren't allowed to give out as many tests as they were before and everything like that. Also, there were a lot of overhead costs, and there still are today, because every single time you put in a claim, then there's someone sitting at the desk going through the claim, working with the doctor to see how much that costs and how much they should get reimbursed for, and then there's follow-up costs. I'm sure everyone here has dealt with that in some way. And it's just complicated, and people hate it, and people continue to hate it. But costs just keep going up, premiums keep going up, and there hasn't been a really good way to control costs. Today, they've kind of done a blend of HMOs and fee-for-service, and that's where the PPOs came in and point-of-service plans. And what's different about us is that we still have this employer-sponsored system. And other countries do too, but in a different way. The problem with today is that when employer-sponsored insurance started, you would get out of World War II, you'd start at a job, and you'd be at that job for 30 years. So they had this huge pool of people, of young, healthy people and old, sick people in that insurance plan that could keep it running. The problem with today is that people move jobs all the time, and people don't stay at the same job and everything, and they switch insurance plans, and then when you switch, you might not get the same coverage as you did before. And so that's the kind of the tricky part with employer-sponsored. So what is managed care? It's basically just a set package, and I'm sure you guys have all seen your healthcare packages before. It's basically a set plan that says we're paying for this at this rate, and how it's set up is basically it's a contractual relationship between every single doctor and every single hospital, saying if I'm Aetna and I go to GW Hospital, I'll say if if you want to be in my network, you want to be covered by my plan, then we're only going to reimburse you at X amount of dollars for this admission or for this, or whatever it is. So like for a heart attack, we're paying you this much, and you can only take this many patients a year, and all that stuff. So it's a contractual relationship. And GW Hospital has to know, okay, a lot of people around here have Aetna, so we have to take their price. Whereas if nobody takes Aetna, they could say, screw you, we don't need you to take, we don't need your insurance here. So there's a lot of different ways of the financial incentives behind healthcare. As I said before, capitation, which is basically where a hospital or a doctor will, an insurance company will say, here's Chris, take care of him for a year, we're going to give you $10,000. You can either see him once or you could give him a triple bypass surgery. Here's $10,000, you deal with it. And the problem with that is there's a disincentive to see people. So doctors don't want to treat you, they don't want to give you the extra test, they rather you just stay out so they can keep the money, whereas if you keep coming back, they're actually losing money. So there's a lot of different incentives there. They've tried a lot with primary care gatekeepers, so if you've ever had to get a referral from a doctor, that's basically saying the primary care physician says, the insurance company is saying, okay, make sure that they absolutely need to see this pediatric whatever, or podiatrist, or can you just handle it yourself because it's cheaper for them. The problem is that people just write their referrals because there hasn't been a lot of pushback, because when the patient says I want to see a doctor, I want to see a specialist, they're going to see the specialist. So it's kind of just been an extra bureaucratic step, and they haven't seen a lot of cutback on that. So the difference between PPOs, HMOs, and POSs, it's just prices and contracts and how everything's set up differently between capitated and reimbursement and in-network and out-of-network. The good side is that it has been able to lower costs a little bit because there's been a lot of these restrictions where you can't just go to the doctor every day and spend all you want. The cons is that it has distorted a lot of these incentives that I've talked about. There's a lot less choices, so there's a network of doctors. These are the doctors you can see. These are doctors that if you want to see them, you're paying out of pocket. It's complicated. Nobody likes dealing with this. And there's a lot of admin costs. So whereas other countries don't, they just pay for everything, so there's not as much of the people reviewing all of the claims and making sure that they go through and everything like that. So that's one of the differences. So basically the major differences between these three types of plans is that an HMO has a gatekeeper, and all of a gatekeeper is a primary care physician. So you have one primary care doctor and you have to get a referral to make sure that you're not just overspending and going to specialists all the time. And all of the with an HMO, all of the doctors work directly. They get a salary from Kaiser, or they get a salary from whatever HMO it is. So they don't have the same kind of distorted incentives that other types of plans do. They tend to get paid a little bit less, but they're the ones that want to kind of do, this is what I read, is they want to do more. It's for them to just see patients as much as possible instead of dealing with all of the contracts and everything like that. A lot of HMOs also own the hospitals too, so they don't just contract with them. Whereas primary care PPO plans, you can go to any specialist that's in the network. So Aetna, whatever PPO plan, networks with all these different doctors and says we'll accept any of these people. And if you go out of network, you pay. And a POS plan is basically a mixture of the two, is that you have a primary care physician that you have to go to, but there's also some networks, and if you go out of network, you pay, but it might not be as much. This is what I talked about before. This has to do with reimbursement rates. So as I said before, remember when I talked about if you have a heart attack and you're in and you go to a hospital, Medicare's only going to pay $20,000. What was happening that they've seen over time is that since the reimbursement rates from Medicare and Medicaid are lower, that just means that private payers just pay more. So that's why if you're Aetna, then they're charging Aetna $40,000 for a heart attack, whereas Medicare and Medicaid tried to cut costs. So the money has to come from somewhere, and it's just kind of figuring out. So it's kind of like double dip. I mean, you're paying one way or the others, basically. So I know I've taken up a lot of time. I want to quickly just do a little review of how the rest of the world does it, and then open it up for questions. I showed this slide before. We spend a ton more than others. Next slide. Yeah. Here's us. The second highest is Norway. And we spend about $8,000 a person. The next highest is Norway, and they spend about $5,000 a person. We're all in this together. Spending's going up, and that's just kind of inevitable. We're just spending has just been going up just dramatically more in the US than it has in other countries. And this is Switzerland, Canada, Sweden, the UK here too. Next slide. I thought this was an interesting slide. It's a little old, it's from 2006, but as you can see here, this was in 2006, we spent $7,000 a person. Mexico spent a tenth of what we did with $700 a person, $800, and our life expectancy is 78 and theirs is 74. So are we really getting the best bang for our buck? If we're looking at it, it's hard to measure, in healthcare it's hard to measure what's considered healthy, because everyone, that kind of just, you know, is life expectancy the best, or is it quality of life? You know, there's a lot of issues and ethical issues in that, but if you look at it from a pure life expectancy point of view, are we really getting the best bang for our buck? Whereas the Netherlands, they're 80, and Canada's 81, 83 in Japan. So, next slide. I thought this was an interesting slide. The blue here is public spending, and then the second, and the white is private spending, and the top is out of pocket. So we spend more in just public spending than, except for Norway and every other country, but we call them socialists. So it's kind of a weird dynamic where we're spending a lot, and what are we doing wrong if we're spending so much more in public spending, and on top of that we're spending in private? So there's kind of a, it's kind of just a weird comparison. Okay, so one type that you all heard of, you've heard of kind of the single payer system. Britain, Italy, Taiwan, and Canada, they all have somewhat of a single payer system. The good thing is that everyone's covered. No matter if you're a citizen of that country, you're covered. And they've been able to keep federal spending down. That's because they set it like a budget, whereas we have Medicare and Medicaid and everything like that is a benefit. So no matter what its cost, we're going to pay it, whereas they have a set budget. And there's been a lot of backlash to that. There's you know, people say that there's waiting lines, and sometimes you might not get as long as, you might not see a specialist as quickly as you would, and they call it rationing, and so there's been issues with that, and they're addressing that as well. In Italy, there's been a lot of corruption and mismanagement, and still 35% of the people go to private. They also have private insurance as well. They haven't been able to control costs though, so that's one good thing. In Britain, yeah, some people have died on waiting lists for mammograms and stuff like that, and their taxes are a lot higher. That was a big issue in Britain before. But they also have a lot less admin costs. So since they just pay for everything, the government owns the hospitals, they own everything, and they just pay. There's not all of this reviewing, because that reviewing can be up to 20% of the cost is just in admin. And they live longer than we do. No one pays for anything. There's no co-pays. And the problem is that the quality also fluctuates with the budget. So if they have a higher budget, quality goes up. Lower budget the next year, quality goes down. So there's pros and cons to everything. Taiwan's had a pretty interesting experience. In 1995, they had this huge reform in their healthcare system. They went from 41% of the people uninsured down to 8 in 1 year. And basically, they had all of their providers, all the doctors, everyone's private, but the government pays for everything. So it's kind of like Medicare, but for everyone. So the government pays for everything, but all the doctors and everything are private. It's very highly rated. They do really well in all of the measures. And it's only 7% of the GDP. And since the government controls the spending, they can kind of control the pocketbook. They've been able to control costs, and they can negotiate with doctors for lower rates. They have this thing called a smart card, which I think is pretty cool. It's basically every single time you go to any doctor, you bring your little smart, it's basically like a cat card, and you put it in, and they can see every single doctor you've been to, every single record that you've had, everything is on this little card. And so there's none of, and all the bills and everything's on there. And that's something that they look at us as being, you know, a first world country, and that we don't have anything like that. The problem is salaries for doctors are much lower. So in the U.S., the average doctor visit is about $100. They pay a doctor makes $100 every single time you walk in. In Taiwan, they make $14. So there's a huge difference in how much they make. Another one, I know you guys have all heard of the Canadian system. There's a lot of jokes about Canadian system for some reason. They basically have Medicare for everyone. There's no cost sharing. It's the same. It's kind of the same as Britain's system, is that they have a federal budget for it, and everyone's on it. Everyone's covered. They have been criticized for long waiting lists and not a lot of specialty coverage. So it's hard to get referrals. Another way, kind of similar to us, is the employment-based system. And that's Germany has the same one. They have a lot of admin costs as well, kind of like any employer-based system. And Japan and France, they have been able to avoid rationing and waiting lists and everything like that, but they are spending a lot. France is going through a huge crisis with that. They have a huge deficit from all of their healthcare spending. They also have a lot better benefit. Their benefits package is much more extensive and lasts longer. So I think in the US it's still after 3 months of terminating your job, you still have health insurance. I think it's up to 6 months or almost to a year in France. So you're on health insurance for a lot longer. Doctors are paid less, but actually there's huge out-of-pocket costs as well. So when you go to the doctor, you're still paying copays and everything like that, similar to us. Japan has an interesting system where they have the same thing we do with mandatory payroll tax and employer contributions, just like we do here. But everyone's required. They have the individual mandate. Everyone is required to have insurance. So no matter who you are, you have to have insurance. And it's either through what we have as Medicare and Medicaid or through your employer. There's no way to opt out of it. Also, all of their insurers are nonprofit. So whereas here we have Kaiser and Aetna and all these things are for-profit institutions, all of theirs are nonprofit. So that has been able to cut down on costs. Some people say it's cut down on quality too, but that's also a measure that that's kind of debated right now. There's also fixed prices set by the government of how much you can charge for things. They're dealing with a lot of high spending in the future just because they have an aging society, and they're kind of dealing with the demographic issues right now of just a lot of older people and not enough younger people to kind of take care of them. And they also rely a lot on technology. That's one of their big, they're one of the innovators in medical technology. So that's also been driving up costs for them as well. This is my personal favorite, managed competition. In Switzerland and the Netherlands, they have basically very similar to what we have is Massachusetts health insurance, Mass Health, and what we have now is Obamacare. Basically, everyone has private insurance. There's no government money spent. Everyone has private insurance. You have to have private insurance, and it's not linked to your health. It's not linked to your employer, but it's regulated. So that means that you can't be denied for pre-existing conditions. You can't. You can switch your plan every year. They can't increase you by a certain amount once you get older, that kind of thing. So it's a regulated, completely private. It's not like you switch from when you're 65, you go on a government system. There's no government system. It's not linked. It's not linked to your employment. They have one of the highest life expectancies, and there's also an enormous amount of choice. So when you as any individual, you can go into your local online whatever, and you can choose any plan you want. You can change it any year, regardless of where you work or anything like that. And then what they do, like what we're doing with Obamacare, is if you don't make a certain amount of money, then you just get subsidies to be able to pay for the private insurance. They also have a much more extensive benefits package for basic benefits. So there's a lot of measures in the medical field of every 3 years you have to get this test and you have to see a doctor so they have a lot more covered from that. They have good access, no wait lists. Costs are still an issue. But everyone's covered and they don't have to deal with referrals or anything like that. But their costs are going up as well. Okay, I've been talking for a really long time. Can you go to the next slide, actually? There's a couple other remaining issues, kind of these ethical issues. I don't know if anyone has kind of an opinion on. The USDA just had a pilot program in Arizona where they're allowing Pizza Hut and Taco Bell to accept food stamps, and I think it's in Arizona right now. And so there's a big issue right now is, can we really tell people what to eat? Can we really say what we're going to be paying for when it's coming from federal dollars? There's a big issue with the soda tax in New York, as you know, and just taxing soda in general. There's a huge backlash from the lobbies on not being able to tax those things. So if it's leading to diabetes and high blood pressure, do we really have that, as citizens, do we have that, that right? Also a big issue, and this is kind of something that we just grapple with as a country, is should people who spend more on healthcare, should they be paying more? So should your premiums go up by a lot more if you have diseases? But what if you get cancer all of a sudden and you can't afford $1 million treatment? Should you have to pay for that? So there's a lot of ethical issues there as well. Should we do the voucher program? Should we also we don't do cost effectiveness analysis in this country. Or at least with Medicare and for federal programs, we only do cost. We do effectiveness analysis, basically saying, for this cancer treatment, this works 30% of the time, this works 40% of the time. We're going to do the 40%. The 40% of the time one might cost 3 times as much, but we still pay for it because it leads to higher outcomes. So should we do those kind of things? There was an issue a couple years ago about a 92-year-old that wanted these special prostate cancer treatments that would extend his life by 3 months, but it cost like $150,000 per treatment, and Medicare was going to pay for that, and Medicare denied it, and it got into the news and everything like that. So where's the cut? You know, if you're 92, you want, you know, you worked your whole life, you want it, but we can't. Can we really pay for this for everyone all the time? And that's where all the death panels came in. And I'll talk about that more next time. Is who's choosing? What's the, you know, is it if you're 90 you get those payments? Who is really making those decisions? And those are some of the ethical issues that we've been dealing with. One of the major new things people are talking about is insurance that only covers catastrophic issues. So basically, if you go to the hospital and you have a $30,000 bill, they'll pay over, the insurance will cover that, but anything else you pay out of pocket. The good thing about that is that it will cut costs down a little bit. The problem is that that's where all the catastrophic issues, or where all the costs are. And the problem is that if you're paying out of pocket, you might not have the same incentives to do all the preventative medicine that's really bringing things down. So you don't end up, you're more likely to wait until it's catastrophic so your insurance company will cover it. So, so then there's always, this is an issue for everything, is should we go purely free market where if you can afford a triple bypass, you're paying for it, or should everyone be covered? So that's just one of the major issues that is political and everyone talks about. So I don't know if anyone has any comments on these or any other questions. I know I've ran out. And next slide. I wanted to leave some time for Tony to talk about some prevention. I know we started a little late, and now I feel kind of bad. But prevention's obviously, and Tony can talk about this, but prevention is one of the things that people are really pushing for that's going to try to lower costs as much as possible. The problem is that you're up against a lot of different incentives of lobbies. You know, there's an issue where someone sued McDonald's for making them fat. And so those kind of things are always coming up in healthcare. And there's just going to be an enormous cultural change that's going to have to take place eventually, in my opinion. So any questions before? No? I know I talked for a really long time. I'm sorry. Well, if not, Tony, do you want to say something? Or I know people are kind of leaving. I'll be here after if you have any questions. Also, please come to part 2. Leave you with a cliffhanger. We'll talk about Obamacare and just go through everything that was involved with that. But I thought this would be a good basis to why Obamacare really came onto the scene.
Yes, as you know, we run the health and prevention here.